सर स्लाइड शेअर करताय का तुम्ही?
स्लाइड्स मी आताच सांगू केलं ऍक्च्युली मी आता जस्ट एका मिनिट आधी हॉस्पिटलमधून
ओके.
पोहोचलोय.
ओके सर, चालेल.
हा, ते डाउनलोड केलेत,
ओके.
करतो शेअर.
Yes, we are live. We can start now.
येस मॅम.
You tell me when to start. I'll start.
Yes sir, we are live. We can start now.
Slides, I hope visible.
Yes sir, visible.
Okay, great. So we'll start directly.
सर कॅमेरा बंद आहे का तुमचा?
Camera बंद आहे, on provide. Done?
Okay sir, it's visible. So good evening everyone. It's my immense pleasure to invite our audience and our esteemed speaker, Dr. Akshay Dalal sir. On behalf of Glenmark Diabetes Care Team, I take this privilege to invite Dr. Akshay Dalal sir. Sir is a cardiologist practicing at KIMS Kingsley Hospital, Nagpur. And sir has a wide experience in treating Indian diabetic as well as hypertensive patients. And with his experience, Dr. shall be discussing about the optimizing outcome for hypertension in patients with diabetes and CKD and coronary artery disease. Over to you, sir.
Thank you for your kind introduction. Sir, as we have already discussed regarding our topic, it is about hypertension in patients with diabetes, CKD, coronary artery disease. This is a spectrum, and most of the times, or quite few of the times, we can see or we are able to see all these complications and comorbidities in a single patient. So let us see how we can manage and go ahead by decreasing the morbidity and disease severity of these patients. So, hypertension and diabetes, and there are significant risk factors. One is family history. Let us see. 30 to 35% of hypertensions are detected to have coexisting diabetes. We see these kind of patients in our health checkup patients, where we are screening the patient for something and we are finding patients with having hypertension, diabetes. The patient's HbA1c may come to, let us say, 10, 11, and the patient is not even aware that he or she was having such things. So, according to recent data and according to recent guidelines and cutoff of hypertension, we are seeing the prevalence of hypertension in adults. It may at times, according to few experienced clinicians who are much more experienced than me, they are saying that we are seeing in almost 1 in 4 to 1 in 3 adult patients having hypertension or at least pre-hypertensive. The prevalence is significant. The only thing is whether we are able to pick things up or we are able to screen these patients is not, that is very important. So as compared to diabetes, it is 1.5 to 2 times greater. Unfortunately, we are seeing these patients in younger age as well. So the common risk factors uh, promote diabetes and hypertension. Lifestyle is one, family history is another. These both the diseases are associated with atherosclerosis, vascular inflammation, and endothelial dysfunction, which can lead to acute coronary or chronic coronary syndrome, then structural remodeling, eventually leading to microvascular and macrovascular changes. Vascular damage and endothelial dysfunction is amplified with diabetes, and when hypertension and diabetes coexist, yes, with these two diseases coexisting, the disease severity and progression is very significant. So individually managing both these patients is very important, and managing both the disease conditions is very important. So all these things can lead to micro and macrovascular disease. Eventually can lead to cardiovascular, peripheral vascular, or cerebrovascular disease. It can lead to coronary artery disease as well. In individual patients, some other system may be affected more than the other system. So we'll have to pinpoint regarding that. So comorbidities are there. Hypertension can be associated with obesity, can be associated with dyslipidemia, type 2 diabetes mellitus, prehypertensive. In Indian scenario, what we have observed is that hypertension is associated with sympathetic overdrive much more as compared to Western counterparts. Even age more than 65, the prevalence is more, comorbidities are more. Younger age, lesser comorbidities. Hypertension with cardiovascular disease, it is significant, and renal impairment is also significant. So globally, overall, the prevalence of CKD was seen as having 27% in adults with hypertension. In Indian studies, the prevalence was somewhere around 7 to 36% in adults with hypertension. It depends depending on variations such as patient education and other factors. Earlier, if the patient gets to hospital, then we can prevent the disease progression. According to ESC 2024 guidelines, the blood pressure targets have been revised. So, class 1 systolic blood pressure target is 120 to 127. Diastolic blood pressure is 70 to 79. It is class 2B. Treatment guidelines are there. These days we are also seeing or cross-checking the patient's blood pressure with ABPM and home-based blood pressure management and observation, but just to make sure we are not missing anything. Systolic blood pressure targets is somewhere around less than 130. So, pre-treatment symptomatic orthostatic hypotension is seen in elderly population, so we have to take care of these things as well. In frail patients, we should be a bit less aggressive, try to revise the targets. If patient's systolic blood pressure is more than 120, then we should at least educate the patient that he may be going into a pre-hypertensive state and he should watch his hypertension. According to guidelines, non-elevated, that means normotensive or normal blood pressure is mentioned as systolic of less than 120, elevated blood pressure as 120, 139, and hypertension clear we label when the blood pressure is more than 140. So ACCH guidelines vary a bit, ASA guidelines vary a bit, but whenever the patient is from 120 to 139, we should start at least with the lifestyle modification as well as patient education. Once the blood pressure goes more than 120, the associated comorbidities may also be there with the prolonged exposure to higher blood pressure. This could be cardiac diseases and CKD as well. So there was a BP Road research group where intensive blood pressure control in patients with type 2 diabetes mellitus was done. Patients included were more than 50 years old with type 2 diabetes mellitus with elevated blood pressure and with increased risk of cardiac risk factors. Primary outcome composite of the first occurrence of non-fatal stroke, non-fatal myocardial infarction, treatment or hospitalization for heart failure, or death from cardiovascular cause was there. Almost 12,800 patients were there. Mean age was 64 years, and men were almost 55%. One group they were targeting intensive antihypertensive treatment, another they were targeting standard antihypertensive treatment. And what they found out was that with intensive treatment, non-fatal stroke, non-fatal MI, heart failure or death was significantly less as compared to standard group. Same thing with serious adverse events with intensive group. There was no significant change, but non-fatal stroke and MI, there was a significant difference. So in patients with type 2 diabetes mellitus and increased risk of cardiovascular disease, incidence of MACE was significantly lower. Intensive therapy treatment targeting a systolic blood pressure of less than 120 seems reasonable than with standard treatment treating systolic blood pressure of less than 140. Here we can make an exception depending on the patient condition as well as the age. If the patient can tolerate less than 120 or even 110, it's fine. If the patient is complaining of any orthostatic hypotension or blackouts, then we may have to be a less bit liberal with the blood pressure levels. We can keep 140. Otherwise, also according to guidelines, the target blood pressure systolic in elderly patients who are more than 150, we can accept 150 systolic as a target blood pressure, and lesser if and only if the patient can tolerate. So recommendations for the treatment of confirmed hypertension in non-pregnant people with diabetes mellitus are almost 120 if possible, and 130 we can see. So initial blood pressure, if it is more than 150 by 80 and less than 150 by 90, then start one agent. If it is more than 150 by 90, then start two agents. Whatever we are going to do, we have to stress upon lifestyle management, modification in management. If involvement of kidney or heart is there, like albuminuria or coronary artery disease, then definitely some cardioprotective or nephroprotective agents like ACE inhibitors should be preferred. If no, we can start with any of the three first line drugs for hypertension. In patients whose blood pressure is more than 150 by 90, same thing with albuminuria or coronary artery disease, ACRBs should be there. Diuretics may be plus or minus. ACRB will be first drug, CCBs or diuretics depending on patient condition. Assess the blood pressure management and adverse effects of whatever drugs we are seeing. If the treatment is well tolerated and blood pressure goal is achieved, no need to worry. If not meeting the blood pressure target, then we'll have to add a drug from another class. Whichever class we have started, we'll have to add from another class. If no, then we'll have to add drug from another class as well. If there are adverse effects, then change the class of drugs. If the patient is not meeting the goal or adverse effects are more, then we may have to change the drug. We may consider adding MRA if the patient is not controlled by adding all the first three class of drugs like ACE, ARBs, CCBs, and diuretics. But while doing that, we'll have to keep serum potassium and serum creatinine in mind. To individualized therapy is cool rather than blindly adding drugs. Guidelines for the management of hypertension in patients with CKD and type 2 diabetes mellitus are almost same. ACE, ARBs. In stage 1 to stage 3, ACE or ARB plus CCB or diuretic, whichever is well tolerated. Increase the dose if required depending on the patient's blood pressure. In stage 4, stage 5, ACE or ARB in the appropriate dose. CCB or loop diuretics. Here, loop diuretics will be preferred for their diuretic effect if the patient is not on dialysis. In stage 1 to stage 3, we can go with either diuretics. Also, treatment with antihypertensive drugs, RAS inhibitors are recommended as first line drugs, ACRB for their kidney protective effect to decrease the albuminuria as well with or without diabetes. Now, while starting RAS inhibitors, we'll have to keep albuminuria in mind and some potassium as well in mind. If the patient is diabetic, then definitely the role for RAS inhibitor is much more because it has got both nephroprotective effect as well as reduced albuminuria. RSSDI guidelines for management of hypertension in patients with diabetes. Same thing, first three line of drugs, ACRBs, CCBs or diuretics. Telmisartan or azilsartan to be preferred. Telmisartan we generally prefer. Experience is more with telmisartan. If not controlled or not tolerated, then we can go with cilnidipine. Amlodipine has got some issues with pedal edema. Significant number of patients, almost 10% to 15% of the patients may have pedal edema. Some tachycardia is also observed in amlodipine, which is not seen in cilnidipine. So cilnidipine can be preferred, can be used in patients with coexisting cardiovascular disease, CKD, and other complications as well. Elderly patients also CCBs are safer to use. So regarding telmisartan, there are takeaways from on-target and transient trials. There is reduction in cardiovascular mortality, all-cause mortality, revascularization, worsening of angina, delays the progression of CKD to end-stage renal disease, reduces albuminuria, protects against new onset diabetes mellitus. There is significant reduction in the incidence of non-fatal MI and stroke if blood pressure is fairly controlled. RAS blockade provides optimal cardiac protection in high-risk patients, and if the patient is actually having some heart failure, then the RAS blockade is preferred over and it is one of the four pillars for heart failure management as well. The meta-analysis of 20 randomized controlled trials, including more than 25,000 patients, showed telmisartan therapy is likely effective in the improvement of proteinuria, albuminuria, or in the prevention of progression to proteinuria, albuminuria. So in both cases, it is safe and prevents the disease or slows the disease progression. Antiproteinuric effect of calcium channel blockers. Cilnidipine has got some additive effect if added to a RAS inhibitor in patients with CKD and hypertension. In this Carter trial, it was observed that systolic blood pressure was slightly but significantly greater at 2 months of treatment in amlodipine group than in cilnidipine group, but did not differ in other parameters. Diastolic blood pressure did not differ, but heart rate control was better with cilnidipine group as compared to amlodipine group. At 12 months of treatment, UPCR had decreased with cilnidipine group, but not in amlodipine group. So cilnidipine can be preferred in patients, or rather, our nephro colleagues are using cilnidipine in preference to amlodipine these days. It is superior to amlodipine in preventing the progression of proteinuria in hypertensive patients when coupled with the renin-angiotensin system inhibitors. It has also positive effect on insulin sensitivity in patients with essential hypertension. It improves the insulin sensitivity, possibly due to its exerting a vasodilatory action without stimulating sympathetic nervous activity. The Kyoto cilnidipine study showed that switching to cilnidipine, it has got antihypertensive effects equivalent to L channel calcium channel blockers. Proteinuria can be further decreased by switching from L channel blockers to cilnidipine, thereby improving the renal function. Most of our renal nephro colleagues are using or rather preferring cilnidipine or amlodipine due to the same reason. The antiproteinuric efficacy of cilnidipine is also that cilnidipine reduces the urine protein creatinine ratio as well as improves the kidney function in patients with diabetic kidney disease. This is due to dilatation in the afferent and both the vessels in kidneys. So that way it helps. Renoprotective and antioxidant effects of cilnidipine are also seen, which can also be helpful. So cilnidipine has got greater nephroprotective and antioxidant effects than amlodipine, but safe, tolerated, lesser side effects. Blood pressure reducing proteinuria and renoprotective action of cilnidipine is seen. If we change a patient with over cilnidipine from amlodipine in a patient with edema, there is a reduction in pedal edema. Edema had significantly resolved in patients that we have seen in our clinical practice as well. We have to add diuretics for the short term as well, just to increase the efficacy or decrease the symptoms fast. So effect of morning and bedtime dosing with cilnidipine is not significant. 24-hour ambulatory monitoring has shown that there is no significant variation. Cilnidipine can be administered once daily. It is an effective antihypertensive drug. Regardless of the time, timing does not matter. We can target time only if there is no significant nocturnal dip, then nocturnal or bedtime dosage can be managed. Or if the patient is having any reflex tachycardia or something like that, then we can go for morning activation, morning dosage. It depends on patient's comfort as well. Cilnidipine inhibits the sympathetic nervous activity and improves the pyroreflex sensitivity in patients with hypertension. So heart rate is not increased. It is heart rate neutral, or there is some 1 or 2 beats decrease in the heart rate. So it can be preferred in patients with high sympathetic activity. So he attended study in Japanese post-stroke patients. The proportion of patients in whom clinic blood pressure was well controlled increased from 21.5% to 65.3% in cilnidipine treatment, with more difference in effectiveness among the various clinical subtypes of stroke. Cilnidipine has been found to be effective in treating uncontrolled blood pressure, and it was well tolerated in Japanese post-stroke hypertensive patients in real-world setting. Cilnidipine is a L and N-type calcium channel blocker. When added to renin-angiotensin inhibitors, improves the ambulatory blood pressure profile, suppresses cardiac hypertrophy in hypertensive patients, and also with CKD patients, which have been observed. With as compared to CCPs with cilnidipine, with respect to ambulatory blood pressure, the 24-hour and daytime systolic blood pressure in cilnidipine group were significantly lower after 24-week treatment period compared with other CCP group, in spite of similar ambulatory blood pressure levels at baseline. So LV mass index is also significantly improved in cilnidipine group as compared to other CCP group. So coming back to our topic, the drug combination helps prevent progressive kidney damage in hypertensive patients. It has got renal protective effect. Cilnidipine has provides effective blood pressure control, reduces heart rate, it is cardioprotective. There is lesser incidence of pedal edema as compared to amlodipine. According to API guidelines, the use of cilnidipine in hypertension and diabetes, they are endorsing it. And cilnidipine improves the insulin resistance in patients with hypertension and type 2 diabetes mellitus. So it is safe and should be used in patients with type 2 diabetes mellitus.
Thank you, sir. There are some questions I would like to ask. Sir, which patient profile benefit the most from adding metoprolol to telmisartan with cilnidipine combination?
Any heart failure patient of heart failure, the guidelines suggest that a beta blocker should be there. Any acute coronary syndrome patient who have had any form of reduced ejection fraction, or even at times with mid-range ejection fraction, metoprolol will be a part of this drug, this combination. It has to be there in the prescription of a cardiologist. If there is increased sympathetic activity and patient is having tachycardia, then also we may consider adding metoprolol. If the blood pressure is not controlled and patient is also having tachycardia, I may think of adding metoprolol in such types of patient.
So thank you very much, sir. Thank you, doctor, on behalf of the entire Glenmark diabetes care team. And sir, I express my heartfelt gratitude to you for taking out time from your busy schedule and letting our audience with your presentation and experience sharing session, sir. So we will look forward to connect with you soon on such scientific work, sir. Thank you very much, sir.
Thank you.
Yeah, to
The
technical team,
permission
we
will
can
continue.
edge. Yes, yes, yes.
Okay, okay. Thank you. Thank you, doctor.